Thank you for joining us today. I want to welcome everyone to the 2023 STS webinar series. Today's webinar is titled Commonalities and Differences, the Shared Experiences of Underrepresented CT Surgeons. Please note this webinar is being recorded and will be available tomorrow morning on the STS website and STS YouTube channel. We invite you to become a member of STS if you're not one already. You'll enjoy a variety of discounts, benefits, and opportunities to help you grow professionally. Learn more at sts.org/membership. At this time, I am pleased to introduce our STS moderators for this evening, Drs. Fatima Wilder and Ian Bostock. Dr. Wilder and Dr. Bostock, welcome. Let me turn it over to you.
Good evening, everyone. On behalf of the Society of Thoracic Surgeons Workforce on Diversity, Equity, and Inclusion, we are very excited to welcome you to tonight's webinar. My name is Fatima Wilder. I'm a thoracic surgeon at Brigham and Women's Hospital in Boston, Massachusetts.
And my name is Ian Bostock. I'm a thoracic surgeon at the Medical University of South Carolina in Charleston, South Carolina.
I'm going to share my slides with you all. So this evening's webinar was inspired by a series of experiences, interactions, and conversations that I had with various surgeons in our field. And listening to their stories about their professional and personal lives, I found myself wondering, are there things that people are doing and experiencing in their personal lives and in their careers that, if shared, could benefit the greater community? And I found myself thinking the answer must be yes. For that reason, we asked the wonderful group of surgeons that are joining us today on this panel to share some of those experiences, both the positive ones and maybe the less than positive ones, with the goal of informing all of us in this community, educating us about ways that we can better support ourselves and our colleagues, and find ways to address the things that have not yet been addressed. After we hear from our panel of speakers on topics such as being the only minority in the room, being a foreign-born surgeon working in the United States, and the challenges surrounding pay as an underrepresented minority surgeon, we'll hear from a group of panelists who will share further on some of their experiences around these topics. And then we'll end tonight by answering questions and having further discussion, hopefully inspired by you, our audience. But before we do that, I wanted to share some information with you to provide a bit of context. The definition of underrepresented in medicine by the AAMC is a racial and ethnic population that's underrepresented in the medical profession relative to their numbers in the general population. This includes Blacks, Mexican Americans, mainland Puerto Ricans, and Native Americans, which within this category includes American Indians, Alaskan Natives, and Native Hawaiians. And I would venture to say that we should include Asians in this community because many of the experiences that they have that you'll hear about tonight are similar to those of the people listed on this page. So when we look at the breakdown of underrepresented in medicine minorities within our field, as of 2018, 16% of CT surgery trainees and 12% of faculty identified as underrepresented in medicine. In 2018, 24% of CT surgeons identified as Asian American or Pacific Islander, 3% of CT surgery faculty, and 4% of CT surgery trainees identified as Black or African American, 5% of CT surgeon faculty identified as Hispanic, and 24% of CT surgery trainees identified as women, which is less than that seen in the general surgery population. That's about 36% representation of women. And when we look at the I-6 applicant pool in 2019, 58% of the applicants were white, whereas only 5% were Latino or Hispanic and 2% were Black. And then when we look at this study, which was published in 2020, it was a survey that was sent out to all of the STS members by the Workforce on Diversity and Inclusion. They asked several questions, one of which is listed here because I thought it was very pertinent to our discussion today. And the question reads, have you ever felt unfairly treated, such as marginalization, mistreatment, harassment, exclusion, bullying, lack of promotion, or feeling diminished by your colleagues within the larger CT surgery professional community because of your race, ethnicity, gender, sexual orientation, religion, age, or disability status? And what was striking about this, and which is really a big reason why this conversation needs to be had, is that of the people who responded yes, the majority were female at 69.7%, and Black, African, and African Americans at 82.6%. So with that, I will be introducing our first speaker, Dr. Mimi Seppa. Dr. Seppa is a thoracic surgeon at Indiana University. She is a native of Vietnam. She was born there and grew up in Montreal. She completed her medical training here in the United States. She obtained her medical degree at Duke University, where she stayed for general surgery residency. She went on to do 2 years of research fellowship at Memorial Sloan Kettering Cancer Center for her time there, and then she completed CT surgery residency at Duke. Dr. Seppa joined the faculty at Indiana University with a clinical focus on general thoracic surgery, thoracic surgical oncology, and minimally invasive surgery. Her research interests are in thoracic surgery outcomes, lung cancer screening, and workforce diversity. Dr. Seppa is currently an associate professor of thoracic surgery at Indiana University. She's additionally the program director for the CT surgery residency program, the vice chair of DEI for the Department of Surgery, and the deputy chief of surgery at the Rowdybush VA Medical Center. Dr. Seppa will be sharing with us her story today from the perspective of being a foreign-born woman working as a thoracic surgeon here in the United States, and how that has impacted her experiences in her practice. Dr. Seppa, the floor is yours.
Thank you. I just wanted to confirm that you can see my slides.
Yes.
And thank you, Dr. Bostock and Dr. Wilder and the STS for inviting me to join this webinar. I by no means, and I fully acknowledge that my experiences are unique, and I by no means claim to be speaking for all Asians, but hopefully in sharing my experience and experiences, we will have a window as to what it might be like for someone who is Asian in the field. So as mentioned, this is where it all started off for me. I was born in Saigon, Vietnam, about a month before the fall of Saigon. So if you ever see footage or images of the US Embassy and the US Army vacating Saigon, that was me. That was, my family and my immediate family. I was just over a year old and almost died, to be honest, along the way, because it was a pretty long journey. So we went from the US Embassy in Saigon and then went to naval base after naval base. And then ultimately I ended up in Montreal and grew up in Montreal. During my late teens, my parents got a little frustrated with the political unrest in Quebec and their constant threat to secede from Canada. So they sent my brother, and my brother is also a cardiothoracic surgeon. He's a heart failure and transplant surgeon at Northwestern. They sent us to live with my grandmother in North Carolina. So I finished high school there, then went to undergrad medical school and did all of my surgical training there. And then I moved to Indiana, and it was my first faculty position, and I'm still there. So I will say, in my experience growing up, I was subjected to the typical and usual Asian slurs, kids running around me, making sounds that they claim to be some sort of Asian language, making faces at me with slanted eyes. In college, every once in a while, I would be exposed to oh, wow, you speak such good English, which is ironic to me because good English probably isn't good English. It's probably better said as, you speak English so well. And then also is funny to me because I was 1 month old when I came over. So, there's no reason why I would have an accent, but everyone assumed that would not be the case. I'd say during medical school, I never really had any experiences that stood out. But during surgical training, I did have a patient who specifically refused my hair on account of the fact that I was from Vietnam. We were at the VA. The patient was a Vietnam vet, and I completely understood where the patient was coming from and respected his wishes. That was not the time for me to expect or want any of my teammates to stand up for me or anything like that. I was more than happy to respect the patient's wishes. And then I met my husband, and then I had to face the name change, the conundrum of the name change. And I bring this up because at the AAPI STS webinar a couple of weeks ago, Dr. Kathleen Burfield had mentioned that perhaps on some level she was protected by her name, Kathleen Burfield, which was not at all Asian. And I was sort of facing the opposite conundrum, right? So my husband is of Hispanic American, is a Hispanic American of Argentine Italian heritage. And I honestly didn't want to be deceiving with the last name Seppa. And I was concerned that if patients came in the room and all of a sudden saw me, they might be surprised and might not like the fact that I'm Asian and not Seppa, I guess. But in the end, I did change my name on account of the fact that I acknowledged that if I had married an Asian person, I would have certainly changed my name to that Asian name. And so I didn't want to not respect and honor my husband in that manner by just because he wasn't Asian. And then finally, as faculty, I would say I had faced Asian bias. This was also brought up during the AAPI STS webinar. Dr. Wood had asked the panelists if they had faced any sort of bias because Asians typically look younger than their stated age. And I will say, certainly as faculty, I have been asked numerous times whether I was old enough to do the operation, whether I really was fully trained. I put in height bias in there, partly as a joke, but also because on some level, I think people associate height with age. And so they assume because I'm 4'11", I may be younger than my stated age. And I will say, honestly, of all the attributes that I have, the physical attributes, not a day has gone by where someone has not made a comment about my height. So everything from side jokes to, are you tall enough to reach the operating room table, from patients, questions like, do you need steps to operate on me? Do happen. And of course, as most women in any field, particularly the medical field and in surgery, I have faced gender bias. I really didn't face any gender bias up until the fact that I was up until the point where I was a faculty member, but everything from side comments, being mansplained, being dismissed in meetings, and a couple of times being overlooked for leadership positions. Now, I will say that was not recent. So with that, I want to review just a few definitions. So a minority is a number or part, especially a number that is less than the half of a whole, so less than 50%. A racial minority is a person whose race or ethnicity is a non-dominant race within the group. So in the United States, racial and ethnic minorities are generally considered to include Hispanic, Latinos, African Americans, Asians, Native Americans, Hawaiian, Pacific Islanders, and those of 2 or more races. And I bring this up because during the STS AAPI webinar, once again, there was a little bit of a debate as to whether or not Asians are minorities. I say 100% Asians are, right? And so we are, even though we only represent 6% of the US population, and despite the fact that we are roughly 20% of physicians and CT surgeons are Asians, we are a highly represented minority, but at the same time, we are subjected to moments and experiences that are unpleasant and create a negative work environment. And then finally, I want to introduce the definition of intersectionality, which I'm sure most of you already know, but it's the interconnected nature of social categorizations such as race, class, gender, sexuality, disability, etc., creating overlap and interdependent systems of discrimination or disadvantage. And in that, people who meet one or more than one minoritized category are, their disadvantage is sometimes additive or even exponential. For instance, we know that women make less money than men on the dollar. Well, African-American women make even less than women who already make less than men. Another example would be that, minoritized females, so, Black and Hispanic women report sexual harassment at a much higher rate than Caucasian women. And with that, I thank you for your attention. I thank the STS for finding this an important topic to be discussing.
Thank you so much, Dr. Seppa, for that. I'm going to hand the mic over to Dr. Bostock, who's going to introduce our next speaker.
Thank you. Thanks, everybody. So now we're going to hear from Dr. Jabari Swain. Dr. Swain is a heart transplant surgeon and global health scholar. He's a native of Atlanta, Georgia, and began his career as an undergraduate student at the University of Georgia, followed by med school at the Medical College of Georgia. He began residency at Morehouse School of Medicine, then spent some time at the NIH, and then subsequently finished his general surgery, spent a critical care year at Brigham and Women's Hospital, where he eventually obtained a master's in public health and also ended up finishing his general surgery training there. He has a passion for global health and has spent time in Rwanda studying outcomes for cardiac surgery and rheumatic heart disease. He went on to do CT surgery fellowship at the University of Pennsylvania, followed by an advanced fellowship in cardiopulmonary transplantation and mechanical circulatory support. He remains there as a clinical associate surgeon at the University of Pennsylvania, where he currently holds the role of medical executive leading health system integration at Johnson & Johnson. In his spare time, Dr. Swain remains committed to humanitarian cardiac surgery by mentoring residents and medical students in global health. He is also completing his executive MBA at the Wharton School of Business at the University of Pennsylvania with an eye towards a role as Chief Medical Officer. So very excited to hear what Dr. Swain has in store for us tonight.
Excellent. Thank you, Ian. So it was posed to me to comment on the idea of being a single or the only voice in the room. And I really just wanted to take an opportunity to share my perspective. You know, being the only voice in the room can be both empowering and challenging. And on one hand, it gives you a unique perspective and the opportunity to represent and advocate for your community. However, on the other hand, it can be isolating and put a lot of pressure on an individual to speak up and to have your voice be heard. When you're the only one in the room, it can be difficult to feel like you belong. And it can also be challenging to ensure that others understand your opinions and that they are valued. It can also be frustrating when others don't understand or appreciate the challenges that you face as a minority in your field. And then oftentimes, I think many of us will comment on in our presentations and from the panelists, you'll hear the sentiment of feeling that you have to work twice as hard as your colleagues to gain similar respect. However, I want to try to lean the conversation towards the more positive aspect of being the only one in the room, because it does allow you a platform to raise awareness and to bring attention to issues that may be overlooked or ignored. You can use your unique perspective to advocate for greater diversity and inclusivity in the field. I'll use myself as an example with two lenses, one starting from my fellowship training and then now currently in my corporate role. I did I was a traditional fellow in cardiothoracic surgery at the University of Pennsylvania. And at the time, I was the only African-American male that trained in that program, probably more than a decade or so. And still even now, that remains to be the case. And it was a difficult time, not only just given the profession and the specialty CT being difficult, but on top of that, just, the microaggressions that exist in, healthcare itself. But the important value that I learned was to develop confidence and competence and being able to kind of speak up on my behalf and advocate for myself as I moved through the training. But I'll tell you that, the voice was important, but what was equally important was that there were people in place who listened, and there were folks who served as sponsors and advocates. And, I can name, pretty much them all: Dr. Acker, Bavaria, Bermudez, Desai, at Lurie, Savasco, Zito, Valabajasla, all of them who served as faculty at the time and who, took a vested interest in making sure that I had what it takes to be a finished surgeon. And so I'm thankful for them, because not only did they listen to me, but they heard kind of what, some of my challenges or struggles may have been, being different from other trainees at the time. And I think, to a more specific example, as I worked towards completing my fellowship, I came to my chief at the time, Dr. Acker, and was like, "Hey, Dr. Acker, I'm having ideas of doing something very different." And it was, my initial thought that he was going to kind of like, be disappointed because, the history of Penn is to train leaders in cardiothoracic surgery, but particularly, academic surgeons. So my line of sight was towards something with a bit more diversity in regards to doing some other things in addition to surgery. But to my surprise, he was actually quite supportive. And, when I came to him, he actually was like, that sounds really cool and interesting. Let's figure out how we can make it happen. And so, that was the one kind of time in my fellowship training that I felt empowered because, again, I had a voice and I was able to speak up on what I thought was important to me and what I wanted my career to look like after I left fellowship. But equally important, my chief and program director and others were supportive of that ambition. And so, and many of them remain supportive as I continue the work that I do, and call on them in regards to other, extracurricular sort of things outside of surgery. And then as I pivot to, my corporate life, I'm currently a medical executive at Johnson & Johnson. And, in that role, I engage C-suite executives and help them to understand the gaps in care and providing care to patients, as well as understanding how there may be solutions that we can use to bridge the care that they provide. And in the rooms that I walk in, not only am I often the only person of color, but also because I've chosen to work in the space of therapeutics, I'm also usually the only cardiothoracic surgeon. And so those are, again, spaces where I have to use my voice to not only advocate for myself, but also advocate for the patients that we serve, because I still see patients, but more importantly, advocate for, those who follow me. And I see that as my responsibility, primarily because there were folks before me that, some of my mentors, Dr. Higgins, Dr. Charles Bridges, Dr. Pierre Theodore, who all worked in very similar spaces where they were the only person who looked like them in that space. But because they spoke up and they claimed the space as their own, and they themselves created an opportunity for folks like me to come behind them. And so I guess as I close, I really just want to, leave the final thoughts that, one, it's really important, regardless of what the issue is that makes you different from the majority population, is that you find the confidence, but also the competence to explore and to identify your voice and make sure that it's heard. But equally important to the voice being heard, there needs to be in your corner listeners who are going to hear your perspective, acknowledge it, and allow you to thrive and be supportive in a way such that you can be successful. And that usually shows up either in the way of a mentor or a sponsor, or even just someone who can actually hear, just some of the challenges and validate that, your experience is real. And then the final part I would say is that as you develop your voice and you speak up and identify, your space in clinical areas, be it cardiothoracic surgery or other spaces, also acknowledge that your voice is not only creating a path for yourself, but you're also doing it for the well-being of those who follow and other onlookers. And so I think it's really critically important that we keep our eye on the focus of ourselves, but also be conscientious of speaking up on behalf of the entire community. And so with that, I'll close here and pass it on to the next speaker. Thank you.
Thanks, Dr. Swain. That was some really great insights there. Next, we're going to hear from Dr. Sihag. Dr. Sihag is an assistant attending thoracic surgeon at Memorial Sloan Kettering Cancer Center. She trained in general surgery at the Massachusetts General Hospital and remained there for her specialty training in cardiothoracic surgery. She has spent some time doing dedicated research in the Broad Institute at Harvard and MIT during her residency. Dr. Sihag was the first female to train in CT surgery at MGH for nearly 20 years since being there. Several other women have followed in her footsteps. Her current clinical and research focus is on esophageal cancer. She's building a dedicated research program at MSK, examining the genomic and epigenetic changes associated with disease progression and response to therapy. I'm excited to hear what Dr. Sihag wants to tell us tonight.
Great, thank you so much, Dr. Bostock, and thank you all really for this opportunity. to share a few stories that really capture some of the challenges that I've faced being a minority woman in CT surgery. Undoubtedly, I'm sure a lot of positive opportunities have come my way because of my background. But let me just go ahead and share my slides. Great, can everyone see that?
Yes.
Great, thank you. So let me just start with a little bit of my background. So I was born here in the United States to first-generation immigrants from India, pictured here. So technically speaking, as an Indian American, I am overrepresented in medicine, but of course heavily underrepresented in CT surgery. I think 3% or less of CT surgeons are minority women. I was fortunate to have a few factors in my favor that made it possible for me to even consider becoming a CT surgeon. First off, I had an amazing role model in my mother, who was also a physician. And I also had access to a lot of resources and support to make a very long training pathway possible. Fast forward, I was lucky enough to match at the MGH for general surgery training in 2007. I think by the end of my second year, I decided I wanted to be a thoracic surgeon. I had some amazing mentors there and experiences that shaped this decision. And at that point in time, a 4-3 integrated program was being established to allow for earlier subspecialization for internal candidates in particular. And this was outside of the regular CT surgery match. So there was no specific application process for the 4-3 at that time. And so I basically had to go around to all of the attendings and make my case. And in 2011, I was accepted into the program as the first woman to train in the thoracic surgery track at MGH, believe it or not. Dr. Jennifer Walker had actually trained in cardiac surgery back in 1999, and there were no others in between, though I imagine some may have applied. At that time, there were also no women on the thoracic surgery faculty. My first exposure to a female thoracic surgeon was actually Dr. Roosh at MSK, where I did a visiting rotation. And this was obviously a very formative experience given where I am now. In any case, at my graduation ceremony from CT Surgery Fellowship, I distinctly remember being celebrated as one of the guys. And of course, this was supposed to be a tremendous compliment. To top it off, there was also a wives gift that is given out each year to the wives of the male fellows finishing for their supporting role during the fellowship. And the gift is actually a very nice Waterford crystal bowl pictured here. In my graduating class, none of us, in fact, had wives for the first time ever. And so we were simply given this gift to keep for ourselves. And I still have mine in my living room. So when it came to looking for a job, I was fortunate enough to be considered for a few different academic opportunities. But I definitely encountered instances where my male colleagues were recruited a bit differently than I was. For example, with a trip to the golf course. I recall finding out afterwards that there were actually phone calls exchanged about whether or not I was too aggressive or nice to the nursing staff during my recruitment process. In the end, in any case, things worked out really well, and I took a position at Sloan Kettering, where two women who are more senior to me were actually already on the faculty, Dr. Molina and of course Dr. Roosh. Despite having 3 women on our faculty, these 2 cartoons really summarize some of the everyday biases that I and many others encounter on a daily basis. Here is a male surgeon yelling out commands, and we all know that while this approach seems to be quite effective for a male surgeon, it really backfires heavily for female surgeons. And I've had to really learn how to take a different approach. And perhaps I look young, but after spending a half hour with patients describing the operation and recovery, some patients are actually still left wondering who is going to be doing their surgery. Finally, the topic I was asked to address, which is challenges around salary negotiation as a woman. I think the bottom line here is that there is very little to no transparency in how many CT surgeons are compensated. Obviously, a major step forward would be to improve that. But in any case, a number of factors listed here, including rank, work RVUs, administrative roles, grants, and even operative outcomes play a role in determining compensation, but usually there's no particular formula to plug in. Dr. Erkman actually recently presented very pivotal data that showed definitively that women CT surgeons are paid around 70 to 80% of what their male equivalents are paid. And when I saw this, I started talking to some of my peers at other institutions and found that many, mostly male, were actually compensated higher than me, despite the fact that I live and practice in one of the most expensive cities in the country. So the idea that my compensation was being benchmarked against AAMC data, which is a trend across many institutions, it didn't seem accurate. And so I used these points ultimately to advocate for increased pay last year and was eventually successful after a number of months. I think many of us simply aren't comfortable asking for more money without some type of concrete justification to offer. And I think that having data, having better data, certainly allowed me to negotiate a little bit better and to make the process more effective. So at this point, I think I'll end, and hopefully we can open things up to panel discussion. Thank you very much.
Dr. Seahawk, thank you so much for that excellent and very informative presentation. You had several things in there that I definitely have not heard about before. So thank you. At this time, we'd like to introduce all of our panelists who are going to be speaking tonight and answering some questions for us, just to discuss some of the things that have already been brought up, but also to address some other questions actually that haven't been brought up. So I thank all of our speakers, and I'm also going to just mention each of our panelists so that we all know these faces, many of which are already familiar to the majority of people in the room. Dr. Louis Godoy is an assistant professor of general thoracic surgery at UC Davis. He's actually currently in Mexico, so thank you, Dr. Godoy, for making this happen. Dr. Jason Hahn, who just finished saving someone's life, I believe, is an I-6 resident at the Hospital of the University of Pennsylvania. Dr. Pereira is a professor of surgery, is the CT surgery program director at the University of Utah, and she's a surgical director of the structural heart program. And then Dr. Danielle Spragan is finishing up an advanced heart failure MCS and transplant surgery fellowship at Columbia University Medical Center in New York. So thank you all so much for being here today. In an effort to discuss as much as we can before our hour is up, I would like to direct the first question to you, Dr. Godoy. So would you be comfortable or willing or able to share a specific example of either cultural or race-based discrimination that you've experienced either in your training or as a member of the faculty?
Sure, great. Thank you for the question. And thank you all for being in this great panel. For those of you who don't know me, I was born in Mexico. I'm an immigrant to this country and having moved with my family as a child. I'm also the first college graduate and the first physician in my family. I do want to say that thankfully, along the way, I haven't experienced a significant amount of overt or obvious racism in my path to becoming a thoracic surgeon. I have, however, along the way, have experienced many subtle forms of racism along the way. And I'll give you a couple of examples from when I was a medical student to now as a faculty member. As a medical student, I remember showing up to round on a patient in a white coat, a tie, stethoscope in hand, and walking up to a nurse's station only to have them tell me and yell at me for being late to repair the lights because they thought I was the repairman. No one even bothered to look up and look at my badge or look at my clothing that I was wearing. They just saw me from a distance and assumed I was a repair person. As a resident, another specific example is, being in a room with a Spanish-speaking patient and consenting them for surgery in Spanish, only to be chastised by the nurse who reprimanded me for talking to the patient about their medical condition because they assumed that I was the cleaning staff. The little subtle, I mean, that's more of an overt act. But even, the most recent one, it's just very eye-opening. As a faculty member, I was seeing a patient in clinic. The interaction started off with a question. I think most of us on this panel are very familiar with the question that starts off asking you, where are you from? So it's a very subtle question. I usually answer the question as like, oh, I grew up in this area. And then that's followed up with the question of like, no, where are you originally from? Where's your family from? And, I answered, my family's originally from Mexico. Had a patient then tell me like, oh, yeah, I really like your people, especially those wetbacks, because they work so hard. They're just such hardworking people. And it's one of those obvious questions that it's just, like was mentioned earlier, you don't know how to react to that kind of question in that moment, other than to try to redirect the conversation to the patient and saying like, no, we're not here to talk about me or my background. We're here to talk about you and your condition that I am here to help you with. And so those are some of just the few experiences along the way. A lot more subtle, but there have been overt acts as well.
Thank you so much for that. I think a lot of what you said definitely resonates with multiple people in the room, but in the interest of time, I won't hog the mic. I'll see if anyone wants to comment on that, or we'll go on with another question, and then we can circle back to discussing your experience.
I can make a quick comment. I think it becomes, these experiences become death by 1,000 cuts, right? So you get slighted by the nursing staff, you get slighted by your colleagues, you get slighted by the attending. So you feel overwhelmingly, that you are being discriminated against. And it may be as overt as what he mentioned, but it may be something more subtle, but all of those slights add up and they can really contribute to kind of mental breakdown and distress and feeling not belonging, which kind of will get to my question of attrition is, I think all of those things, a sense of belonging are very important, and having someone continue. So, the death by 1,000 cuts is a real phenomenon, I think.
I was just going to add really quickly. Oh, sorry. I was just going to add really quickly to Dr. Spragan's comment about microaggressions. And I think someone had mentioned it there, Dr. Sipa. Microaggressions are, they manifest in such a way that you often, if someone asks you, well, what exactly did they do to discriminate against you? You can't describe it or put it in words, but you can actually feel that it happened. And, onlookers sometimes can sense it, but, it's incumbent upon them to be empowered to speak up about it. And because I think oftentimes those of us who experience those microaggressions, are really sensitive and hypersensitive, and we have to program ourselves not to overreact in those scenarios. To give it, another example, when I'm taking a resident out or a fellow out, to do a recovery, the nurse will come up and start talking to the medical student, and he's a tall white male, and looks like he's practicing his doctor look, and so they automatically assume that he's running the show. And I've had very, gracious medical students. They're like, well, when you're done, sharing or rehearsing, Dr. Swain is over there and you can tell him the story. And so, it's been sort of those sort of scenarios where we've had to kind of pivot. And, it goes beyond, the stereotype of, being considered the garbage man or, what have you, but really just being slighted by your credentials and having to lead in with your resume or your CV, as opposed to, someone just accepting that, hey, I'm Dr. So-and-so, I'm here to help, or I'm here to, be your doctor, et cetera.
Thank you for those comments. They were extremely, I mean, I have so many questions that I want to ask. One of them, I will say maybe before we move on to our next question is, and I think you touched on this, Dr. Swain, does anyone feel it's our individual responsibility to address these microaggressions or macroaggressions as they come up directly? Or is it up to the institution or maybe our direct bosses? Where do you think the responsibility lies in addressing these issues?
I think there definitely needs to be buy-in from the institutions, and we need to have policies. Like Dr. David Cook mentioned, I know he's on the put a comment in the chat. We got to have buy-in from the top down, from the leadership in our institutions to help set up policies, training, events. Cultural sensitivity events for staff as well. I don't think the burden falls or should fall on the individual person who already has enough on their plate and is having to then deal with some of these micro and macroaggressions.
And you can't just minimize the impact this can have on someone's self-perception. I think identity is incredibly important, and a lot of what happens around us defines that identity. There's this quote that I think of in this scenario that says that I am not what I think I am, and I am not what you think I am. I am what I think you think I am. Does that make sense? So like your outside identity is so much affected by what's happening around you and what people perceive of you. And if what you're perceiving is all these microaggressions, then you don't feel a sense of belonging. So I think one alternative is to try to fight back, like you said, try to get the institution to support you and to defend you against such things. But also another one is to fight from within. And I don't mean to make that sound kind of new age, but what I'm saying is that you are the one that's in control of this perception, right? So you have to, like Jabaris was saying, like you have to not take it so personally. You have to like rise above it, and you have to define yourself in a different way.
And if I may add for a second, so first of all, sorry I'm late and I'm dressed in scrubs. Everyone looks really nice this evening. I just scrubbed out of the case, but from a trainee's thanks. But from a trainee's perspective, I think it's especially important that there is some sort of an institutional or some sort of a leadership oversight into these matters, because I think of cardiac surgery residency training as one of the most formative experiences to not only one's technical and clinical abilities, but also the types of sort of principles that you'll carry throughout with you for the rest of your life and your career. And I think when you're a trainee, you're doing as much observing as you're doing, in terms of enacting cultural changes. And when there's no institutional oversight into these types of matters, I think that most people are sort of, people growing up in this culture normalize certain things that should not be normalized, right? So, when I sometimes talk to program directors, I ask them, do you think that matters outside of technical and clinical acumen are within the purview of training programs and their responsibilities? And my belief in that is that it is an important thing to begin to introduce into a trainee's way of thinking about medicine and the way that they interact with their colleagues.
So I'm gonna pose the next question to Dr. Pereira, and we're going a little bit out of the order that we had discussed, but in light of everything that's been said so far, if you could have a golden ticket or a perfect solution and you can request that from your leadership, what sort of program would you develop, or what sort of policies would you institute to help either change the culture or educate people in a way that would be hopefully effective to address these issues?
Yeah, thanks, Dr. Wilder and Dr. Bostock, and all of you panelists have me sort of awestruck. So I don't know if I'll answer this question perfectly, but I realized that I am the oldest person on this panel, and I've been in practice for about 20 years, and I've had about 10 years of private practice in there and 10 years of academics. And, all of the microaggressions and biases wherever I've worked at all the institutions have been the same. And I can't say that they've always come from my division of cardiothoracic surgery. In fact, the cardiothoracic surgeons that I've always worked with have been the most welcoming towards me and the most supportive. And so for our specialty, I think that actually says a lot. But I can't say that the administration and leadership of various institutions has always really understood the shoes that we walk in every day. And, I was sort of one of the only female surgeons to train in all of the programs that I trained in Cincinnati and Birmingham, Alabama. And I always thought in my training that I just wanted the leaders of the hospitals to just walk with me for a day and kind of see how people reflect, and how many times you're called a nurse and you're too young to do this, and you're too short and you're too petite. And, when we're pregnant as women, like how many steps do you have to stand on to reach the heart, and all of these microaggressions that just add up so much through the years. And I don't know if any of you heard my STS podcast, but to me, after like about 8 years in practice, I just became like hugely burnt out, because I think it just added up through the years of all these comments. And so kind of in middle career, I challenged myself to go back and try to be more extroverted, which I naturally am not, and try to challenge the leadership at institutions and training programs and build a better environment for all of our trainees. And so, now at my institution, I'm proud to say that we're one of the most diverse training programs, and that we really value that. But I do struggle with the leaders of the hospitals, particularly at one of our community programs, because it's not as diverse as the university that I work. And so, in terms of programs and policies, we have all the programs and policies, the EOA and the HR and the discrimination policies and confidential reporting policies. But it's not enough for all of our trainees, I think, to be treated equally and not suffer from all the microaggressions that I think have been spoken about. And so I think that we need to put more women and underrepresented surgeons on the leadership at hospitals. We need to all be like Dr. Swain and get our MBA and lead these hospitals so that they can better understand what we do, I think, on a daily basis. And not until the years of doing that is it going to be equal, but hopefully we'll make slow progress.
Thank you for that, Dr. Pereira. I agree. I think it's the term you having a seat at the table is really what kind of rings true from that statement. In that if you're not involved in leadership, if you're not in a position to be able to influence change, it's going to be much harder, because people can unfortunately tune you out if they don't feel like they can identify with what you're saying, or they don't think it's important enough to bring up. Dr. Sprague, I'm going to ask you a question about, in light of everything we've discussed, what would be your advice to either trainees that are either on this webinar tonight or are going to encounter you in your transition to attendinghood, about not being discouraged about some of the numbers that we presented earlier, and continuing to pursue a career in this field when this is something that we are, discussing openly?
Sure. I think, and this is putting me a little on the spot, but I think there are several things. having allies is incredibly important in this field. I think everyone will realize that this is a very, very, very small field, and people know each other either through training, through committees. There are fewer than 6 degrees of separation. I'd say there are 2 to 3 degrees of separation. So having an ally is incredibly important. So whether you find someone like me, like Dr. Wild, anybody you can find that can really be a sounding board for you and can help you navigate the waters, someone who's done it before you, is really helpful. It makes you feel less alone, and it makes you feel it's possible. And even just seeing people on this panel and this, this is very, very helpful, I think. So finding an ally, I think, is number one. I think another thing that contributes is if you find a place when you're training that you feel comfortable and that you feel collegiality, you're going to spend an inordinate amount of time with your colleagues. So finding someone, going somewhere and training somewhere where you feel like you fit in and feel comfortable will kind of keep you going and encourage you along the way. So I think finding an ally and an ally and a mentor that can help you navigate the waters, and then making sure you choose an institution or a training place where you really feel comfortable and supported is very important.
I think just to kind of reinforce some of what you said, Danielle, there's a question in the Q&A that says, as a woman of color in this field, a minority within a minority in CT, how have you been able to handle the invisible pressure of you to always be on your game while also being true to yourself and not burned out?
That's a great question. I think a lot of it starts with having a sense of purpose. And what I mean by purpose is confidence in yourself that you can do just as well and just as much as anybody else, because you can do it. Others may say you can't do it. You may not feel like you can do it at every point, but you can do it. So I kind of always had that notion in my head, and maybe it's just arrogance, I don't know, but like, I can do it. And I'm going to keep going no matter what you try to do. I'm going to keep going. But that's not enough. You really need, as I can't emphasize enough, that you really need people on your side, because like, Jason said, CT surgery fellowship is one of the most formative and challenging experiences that any of us will probably have. So, having people you can lean on is really important. And I mean, really lean on, that you trust, with things that you're going to confront. Dr. Wilder and I both have 3 children, having 3 children and doing cardiac surgery and being a woman, and, it all adds up, all these things adds up. You become like this crazy unicorn, a zebra, whatever you want to call it. And that's okay. But having people on your side and that can bring you along and keep your confidence going, I think is important. But it starts with yourself. You can do it. Believe in yourself. You really can do it.
Thank you, Dr. Spragan. I'm going to go on to one of our other questions from our audience, and I believe this was from Ryan Arrington. The question about what initiatives are currently in place to expose medical students early in their education or to recruit others. Essentially, I think looking to the different organizations like SBAS, the Latino Surgical Society, the Association of Black Cardiothoracic Surgeons, each, I believe, either has mentorship programs and or scholarship programs. I know the ABCTS has a pipeline program that we've just recently started looking at applicants for, that with the goal of creating a pipeline, essentially, to say, okay, let's reach out to medical students, get them early on so that we can expose you to the field and help you learn more about what the opportunities are like and what a day in the life really is like, so that you're not scared away by some of the things that you might hear in the process. And I see that other scholarships are being listed in the chat there. So there are many out there.
And just to reinforce what you said, we are trying to develop a Latinos in cardiothoracic surgery group. We're actually having a webinar on the 20th, I believe, of this month. So just a week away, that will help us sponsor networking and mentorship initiatives. And this is for medical students and residents and faculty.
And I see another question here from Dr. Cook, and I'll pose it to the panel. The question he asks is, are these challenging experiences unique to CT surgery, or is it a healthcare issue? And what is CT surgery doing now to foster an inclusive environment? And he says, thank you for a wonderful webinar. So I'll ask anyone who feels comfortable speaking on it, or I can pick on someone.
I think I'll say just one quick thing. I think it's not necessarily unique to CT surgery. It's just that the numbers are so incredibly small and the differences are so magnified. You know, having, you know, cardiac surgery, for example, 5% or less women, you know, that is a stark contrast. So I think it's definitely not unique. You know, we like to think we're very special, and we are, but it's not necessarily unique to CT surgery. You know, women in tech, things like this have the same challenges, but I think the numbers are just very stark in CT. So
I have to agree with Dr. Spragan. Absolutely, there are other challenges throughout healthcare, and so it will ultimately be a systemic change that will move the needle. But I think, you know, one of the challenges with CT surgery is that it's an old specialty that self-selects for a particular type of population. And, you know, it hasn't been up until recent years that, you know, we've seen a strategic or active focus on bringing in more minorities, bringing in more women. And, you know, I think what we have to keep in mind is that once you achieve that mark, it's not something that's static. It's something that has to be dynamic. Like inclusivity and diversity has to be something that is at the forefront every year as you're bringing in residents and fellows and faculty. So that's sort of kind of a systemic issue that we as hospital systems and health systems have to embrace. And then on top of that, you know, I think, you know, someone had mentioned the mentorship. That's really key. And, you know, I think, you know, I started, you know, with my gauge and eye towards medicine, you know, in SBAS. And, you know, some of the folks that I met there aren't even CT surgeons, but I kept in touch with them and leaned on them. And so we have to also keep in mind that just because a person doesn't necessarily look like you or do the specialty that you are in, does not mean that they can't also serve as an advocate or a sponsor. And so I think that's critically important. Some of the folks that, you know, really developed my career, even in CT surgery, given that there's so few numbers, did not have any background or interest in me in regards to similarities of how I grew up or where I'm from, but they were really vested in making sure that I was successful. And it was that just, you know, lift that they provided, or that ear, or even, you know, that little small special trick that they showed me in the operating room that really gave me a leg up and allowed me to keep moving forward. But just as that happened for me, I have to, you know, also look back and provide that same leverage for others that follow.
Yeah, I agree with that, Dr. Swain. I think, you know, I think all of us would agree that for students, residents, fellows out there, you know, all of us would be more than happy to serve as mentors in part, dealing with any or all of these issues. You know, they're the mentors that you have at your institution that you meet along the way, but they're also, you know, folks that you reach out to specifically and seek out for their guidance. And so I think any of us would probably be willing to serve that purpose.
Dr. Hahn, you were going to say something?
Yeah, you know, these are all great comments. And I think one thing that is a bit unique to cardiothoracic surgery is immensely serious and long commitment that you have to make relatively early on in your life. I think people have to kind of have a sense of what CT surgery is and whether they're interested in it long before they're a third-year medical student applying for the first time, because it is very competitive to get into, and it is something that you have to think about early on. And without particular networks, it's hard to get exposure to unless you do serendipitously come across it somehow. You know, I was born and raised in a family. My parents are both in science, but you know, we were Korean immigrants in a functionally single mother home, and CT surgery was not something that I would have even thought about. I serendipitously landed in a research job after college that was in CT surgery as I was talking to a friend, and look where it's taken me 15 years later. But I mean, all of this to say that sometimes when I have conversations with my colleagues, the way that people arrive in CT surgery is all very different, but a lot of it is often because of some of these under-discussed privileged avenues into the world of CT surgery. And I think it is the ability to be able to shadow your parents or your parents' friends and et cetera, that oftentimes people from different backgrounds may not have access to early on. And that aspect of CT surgery, as Dr. Swain mentioned, does lead to some sort of a self-selecting pool of applicants and residents and future surgeons. And I do think that that is something that has to be intentionally addressed, because it is something that organically perpetuates itself.
I don't know if we have any last words from anyone on the panel, but in the interest of time and to respect everyone's time, I think I'm gonna wrap this up. I think we could talk about this for several more hours, and I know that some of us on this panel are working on things to help push the needle, address the issues at our institutions and in our communities. So I thank all of you so much from the bottom of my heart, and Dr. Bostock and the STS for your presence today, sharing your stories, being willing to talk about some personal aspects of your lives. I think this has definitely been informative, at least for me, and I hope for everyone in the audience. And I hope the conversation doesn't end here, that it just stimulates more conversation and that we can find some real progress, even if it's just baby steps over the next few years and in the future moving forward. So thank all of you so much.
Thank you, everybody, and have a great night and a great weekend.
Thank you, Doctors Wilder and Bostock, and thank you to all of our speakers and panelists today for your participation and insight. This has been so meaningful, and we appreciate you taking the time to share your experiences with us. Thank you. And we'll share these resources when we post the recording to our YouTube page. For more information on STS's commitment to diversity, equality, and inclusions, go to sts.org/diversity or scan the QR code shown. Register today for the 2023 STS Coronary Conference, which returns for a second year of innovative international and groundbreaking science, taking place June 3rd to 4th this year in Miami Beach, Florida. Learn more at sts.org/coronaryconf. Thank you so much, everybody, and have a great night.